The two studies we have published have been the largest studies done in obsessive compulsive disorder.
And so we saw really good results, a median of about 45% symptom reduction.
We saw kids experience a good degree of relief, of reduction in symptoms of OCD over the course of treatment. And that's not lost on us because treating OCD in kids in particular is a little bit notorious for being somewhat difficult.
You've probably heard of OCD, but you don't know that OCD isn't really just about cleaning and organization. It's actually debilitating. It's a condition that causes intrusive, persistent, and really sticky feelings and thoughts that can seize on any topic, from romantic relationships to illness to spirituality, and really anything that matters to you. This can really cause significant anxiety and guilt and shame and discomfort and can make it hard to function in day-to-day life. If this sounds familiar, know that you're not alone. In fact, 1 in 40 people in the U.S. suffer from obsessive compulsive disorder. But help is available. I'm a licensed clinical psychologist with 25 years of OCD treatment experience, so I know that these scary symptoms can be overwhelming. But I also know that they can be managed with the right type of treatment. I lead a team of top-tier clinical experts at NOCD who are trained in the effective treatment for obsessive compulsive disorder. NOCD is an online platform offering specialized, accessible, and convenient OCD treatment. My team and I have helped people take back their lives from OCD through evidence-based therapies that are covered by insurance. To learn more about OCD and to start effective treatment, head to nocd.com. That's NOCD.com. You deserve to live the life you want to live and not the life that OCD wants you to live. And don't forget to subscribe to our YouTube channel so you can stay up to date on our latest podcasts and webinars. Now, on to today's episode. Hi, everyone. Welcome again to another episode of the Get to Know OCD podcast. It's always fun to have colleagues on the show, and today I get to welcome two of my colleagues. With me are Dr. Nick Farrell and Dr. Jamie Feusner. The two studies we have published have been the largest studies done in obsessive compulsive disorder, and both have shown the effectiveness of teletherapy for treating both adults and children and adolescents. Could you both give us kind of an overview, as the two of you were really some of the major pushers in that work, what we were looking at and what we found?
Yeah. So the first study that we published in 2022, that was on our adults that we treated. So we first started treating adults and then added treatment of children and adolescents after that. So what we did is this study, so it's really an analysis of data that we collected as part of the clinical treatment. So it wasn't a kind of pre-planned research study that is like controlled. So this is what's called an observational study. So it's an analysis of the data that we collected in the first about 3,500 adults that we treated. And so what we did is we looked at their outcomes. The primary thing we're looking at is what kind of percentage of symptom reduction we were seeing on the OCD scale that we use, called the Dimensional Obsessive Compulsive Scale, or the DOCS. And then we looked at improvements in other symptoms that are common in OCD, so depression, stress, and anxiety. And we also looked at other things like their quality of life. And then another part of the analysis we did is we looked at, in people that started with mild symptoms, people that started with moderate symptoms, people that started with severe symptoms, what were their individual symptom improvements, to see whether we were helping people regardless of whether they were starting with mild, moderate, or severe symptoms. And then we also looked at how were people's symptoms doing over time, over a period of about a year or so. So we had some data for people that, we continue to send out the assessments, and a proportion of people that continue to fill them out up to a year. So we looked at, are the symptoms generally staying low, or are the symptoms coming back and returning? And so we saw really good results from these. Like in all those categories, we had good results. We had a median of about 45% symptom reduction on that DOC scale. And about 2/3 of the people were considered responders. So the way that we had defined it was at least 35% reduction in symptoms. And we saw that there was good symptom improvement in all ranges, so mild, moderate, and severe, and then the symptoms were largely remained low even up to a year.
Yeah, and then more recently, just in 2024, we the kind of study design or research design that Jamie just described, we more or less did the same thing, only with a child and adolescent population.
Okay.
And just to briefly summarize, found very comparable results. On average, we saw kids experience a good degree of relief, of reduction in symptoms of OCD over the course of treatment. And most importantly, the treatment was well tolerated. That is to say that a majority of kids that went through this treatment, not only got better but were able to persist and complete enough sessions to achieve that benefit. And that's not lost on us, because treating OCD in kids in particular is a little bit notorious for being somewhat difficult. If we compare kids to adults, I think the prototypical adult, can very clearly see and experience how debilitated they've become because of the symptoms. And with that comes oftentimes, by comparison, an increased motivation or willingness to change. Well, we don't see, we're not able to enjoy that quite as much in youngsters, and that's all right. A lot of times the work involves leveraging mom, dad, other caregiving figures, and kind of bringing them into the treatment team, so to speak. But there are unique challenges to addressing obsessive compulsive disorder in young folks. So we're very proud that the data that we've collected with that population have showed, again, outcomes that are equivalent to what treatment effectiveness looks like when children are treated in more traditional in-person or in-clinic settings.
So people will look at that and say, great. Thank you for doing this. I mean, obviously the largest studies that have been done in this, so it really does bring evidence-based treatment to the forefront to show on a wide variety of folks we could do it, and that we can do this in a model, right, that is like what happens in a clinic, and it isn't just what happens in a lab. And obviously we need double-blind studies, right, to show effectiveness of things, but the aspect that has been discussed so much in the field is how do we take what we learned in the lab and apply it to the lives of everybody who we would hope these treatments now are going to influence. And I think that that's what we've started to do, is this dissemination work again, is making sure that now we can say, yep, here's the double-blind studies. Here's what the research has shown is the most effective way to do this. And now we know that we can apply it to real life settings as well.
Yeah, exactly. So it's the real world sample to see how it plays out. And, and there have been other like real world studies as well, but none that have been quite this large. And also because we have, there's some standardization in the way that we do treatment, then it allows us to understand that it is most likely, the effects of what we're doing, and we can measure it. And there's it's still somewhat systematic because we have kind of a general structure for treatment that we do for everybody. I think the other important finding from both these, the adult and the child sample, was that those results that I mentioned, then the median number of sessions to get to those results was 13 sessions. Mm-hmm. And the median number of hours, therapist hours, was about 11 hours to get there. Mm-hmm. So that represents like roughly half of what a standard course of outpatient CBT therapy is, both in terms of session numbers and hours, or really session numbers. So it suggests that these results, we talk about like getting better and also getting better faster, that the results do seem to show that people are getting better faster than more standard once a week outpatient therapy.
And this is, to me, what is really important about incorporating assessments and data into the therapy that we do. We would not be able to just go to, say, insurance companies or payers or other partners and say, hey, we do great work, but we don't have any data to show it, but just believe us, right? The fact that we have this data, that we collect this data, that our members are a part of this data, really are some proof in the pudding here that what we're doing is changing the lives of people.
Absolutely.
What would the two of you say is some of your favorite things about the work we do here at NOCD?
I appreciate how we are never resting on our laurels or accepting that we we've reached some kind of plateau where the overall quality of the service of the product is good enough. In other words, there's a spirit of continuous improvement, I think, in every aspect of the company that is aimed at just trying to make this the best experience that we can for the members that we serve. That comes not only in the clinical product that we offer. For example, when I joined NOCD 4 years ago, we were, for all intents and purposes, limited to treating just OCD. Over the last 4 years, that scope of conditions that we can provide evidence-based treatment for has expanded to include conditions like depression, anxiety disorders, and other obsessive compulsive related conditions like tic disorders, body focus repetitive behaviors. All this is important because more often than not, when somebody's experiencing obsessive compulsive disorder, the research tells us it's likely they're going to be experiencing at least one of those concurrent mental health conditions. And if those aren't addressed properly, they can often, kind of dampen or weaken the overall treatment effectiveness. So being able to innovate in that way and really make the overall, comprehensiveness of the service that much better, I think has been a great feather in our cap.
Yeah, I agree with Nick. I totally agree with that. And there's many things that I like about working at NOCD, and the satisfaction of people getting better, getting a lot better in a short amount of time, and seeing some of their comments when people make comments about it and how much it's impacted their life. It's so meaningful, and it's really powerful. It's really motivating for me, and I think a lot of people. That the other thing that I find to be also very inspiring and something that I enjoy being a part of creating this treatment is the fact that there's a lot of people who have NOCD who are on the NOCD team and who have been part of building this from the beginning. And so this is helped us, all of us, in so many ways, because the three of us, we're clinicians, we treat people, and we have that perspective, but we need more than one perspective, I think, to deliver good treatment and continue to improve it and to make it something that is understandable and acceptable to people, and not having to necessarily do things the way that they've always been done, and having people involved who have OCD, and also another set of people that are involved with OCD are what we call the member advocates, which is peer support. And these are people who have OCD, who've gone through treatment, gotten better, and then they work at NOCD now, and they help support the other people that are getting treatment. So these are people that have walked a walk, they have it, they've gone through the treatment, they can people with OCD can know that they understand what it's like to do it, and then they've also helped us kind of shape the way that we do treatment as well. And then it's also for me, I feel like it's also kind of an accountability thing, because you're working with people that have OCD, and you need to be making something that is good, that makes sense, that works, and we're all working together on this together.
I'm thankful for the two of you and the work that you've done to show that the work we're doing is effective, and that work has come to fruition in terms of being able to get insurance to cover OCD treatment so that we can disseminate evidence-based treatments across the world. And that is just something that I think is more and more important to assure that people don't suffer, right? Because we want people to live the lives they want to live and not the lives that OCD wants them to live. And by providing this treatment to people, we can really make sure that happens. Well, any parting words, gentlemen, before we close off for today?
I'll share that at one time, not all that long ago, I was a skeptic when I heard that this treatment could be done in a virtual setting, I scoffed at the notion. I am now a full-fledged believer, and I would encourage folks, if you, like me, harbored some skepticism, be curious, give it a shot. Um, whether you're someone that struggles with OCD and is having a hard time accessing evidence-based treatment, but maybe have some reservations about what it would be like in a virtual setting, or if you're a clinician, maybe considering joining the NOCD network, but I don't know if I'd really am cut out for virtual work. I think you'll be pleasantly surprised.
Jamie, any other things?
Yeah, I think in a way, speaking to that, the proof is in the pudding, because we know what the results are. We measure them very carefully here at NOCD, and we know how people are getting better, and we can compare that to other ways. And so with all forms of treatment, there can be pros, there can be cons. I think most of the pros really outweigh the cons when it comes to virtual treatment. And way back when, I used to be a skeptic as well. Probably most clinicians used to be skeptics.
Mhm.
Anything kind of new, like, well, I don't know. We've been all doing it this way, and it seems to work. And but and so I think some people and some of my colleagues thought, well, virtual, it's kind of like a substitute if you can't do it for some reason. But it's not quite as good as in person, and you should really try to do in person if you can do in person. But now I think about it totally differently, which is that it can be as good as in person. It can be better for some things. I think there's still some cases where people need to have some things in person that they can't totally do virtually. But most of the treatment, and for most of the people, can be done virtually, and it can be done quite well.
Awesome. Well, thanks to both of you and the work you're doing in helping to disseminate the exposure and response prevention evidence-based work that we do to assure, again, that people are going to live the lives they want to live and not be ruled by obsessive compulsive disorder. And thank all of you for watching the Get to Know OCD podcast. If you're looking for help for OCD, check us out at NOCD.com. That's NOCD.com. We'd be happy to meet with you. We have people on our care team waiting right now to be able to take your call. And if you like this podcast, you can subscribe to the NOCD YouTube channel to see more episodes, and also other things that we do, like our Wednesday night webinars that we record and put up there, as well as lots of other great content from our members and from our member advocates. We hope to see you again soon. Thanks for watching.